I think I'd like to take this opportunity to invite the speakers, Dr. Stevens, Dr. Gururaj, Mr. Wako. If you want to sit up here, hopefully we'll have time for just a few quick questions. I know we're running quite over, so hopefully just 3 questions that our panelists can answer. So, I guess while we're waiting for questions, I did see some hands raised. Well, I get Amber.
Hello, this is Amber, and my question is for Mr. Wako. Mr. Wako, you showed us a video of the disaster drill in Kenya. Was there an incident command center that was, established or initiated for the drill? And who was the incident commander in that instance?
So I think maybe we'll be able to take all 3 questions at the same time, and then we'll ask our distinguished panelists to answer them. Dr. Khalid.
Hi, Cal Bassini again. The same question for Mr. Wako. So how do you take care of the incentivizing, the incentivization for EMS groups in areas where patients may not be able to pay? So we have a lot of low income or incredibly poor patients who have high needs in rural areas, and there's no EMS support in many of the countries that I work in. And I can't get an ambulance system in because it's a profit system. Any thoughts on that as well?
And I believe one last question.
I'm Kate Douglas, also from GW. Kind of bridging on what Khalid just said, actually. My question is about the intersection between the public and the private sector. Because I think in many countries you have this real obvious disparity, and yet you've got the systems, the EMS system is developing where you have a lot of private ambulances and a smaller public sector, but you've got lessons learned, and it's obviously an issue of equity and social justice, as we had brought up earlier in the day. So I'm just curious if you guys have experience or lessons learned or suggestions regarding that intersection and how to, potentially utilize things that are available in one side and bring it to the other and whatnot.
Thank you very much. And maybe I can add my own question to that. It seems like trauma care is all comprehensive sort of package, all the way from EMS to hospital, post-hospital policy, regulations. And I know in your experience where there are ideal systems like the US and less ideal systems in development, if you had to choose, which components do you think would be the most cost-effective individually in terms of implementation? And I know there's a tremendous amount of experience on this panel, and hopefully we can get all these questions answered. So maybe we can proceed with everybody getting a couple of minutes to answer the questions as they see fit. We can start with Mr. Wako.
Okay. I needed clarification on the first question because I didn't hear it clearly, but I'll answer the second, then when she's ready she can answer. The issue of incentivizing ambulances in rural areas, it's one of the challenges that we do have, of course, in Kenya. And the thought here is the way to move forward is sort of a social security type of system, where we have what is called the National Hospital Insurance Fund, NHIF, and we are hoping to convince the government that if people paid a subsidized amount, like everyone paid it, something like less than probably $1, if everyone paid it, because we're 40 million, that would be easily quite a bit of money that could basically supplement in the rural areas. So that's one of the methods that we are trying to sort of go ahead with. Then the issue of private-public partnership, I think on that, my answer would be what we're trying to do, and like for this incident, what we did is we actually approached one of the insurance companies, like Jubilee Insurance, and for that day, all the actors were provided basically free insurance in case an injury did happen through our activity. But what we had to give them for that was the publicity. They had to put their banners up and make sure that they got the publicity. Many private businesses and companies do have what is called a CSR, corporate social responsibility, and through that, there are opportunities for some ambulances, like there's a mobile subscriber called Safaricom, which is part of Vodacom, and they basically have supplemented and bought ambulances in some of the rural areas. So again, the CSR is one of the avenues for public-private partnership. And then, yeah, so that was, I don't know if you had the question.
So it's actually a very brief question.
Okay.
I was asking about the disaster drill that was conducted in Kenya, and I was asking about whether there was a incident command center that was set up, and who was actually the incident commander.
Okay, a very good question, and I'll assume everyone knows the incident command. Okay, so the incident commander was a unit called the National Disaster Management Unit, NDMU, which is part of the police force. After the airport fire on August the 7th, 2013, the President, His Excellency Uhuru Kenyatta, basically set up a unit within the police force to handle disasters, because we have had another unit called the National Disaster Operations Center, NDOC, and the two basically do coordinate. So they did set up an incident command center, and in later parts of the video you'll see the demonstration of the incident command center that was basically used to do the coordination throughout the activity, because we're trying to encourage the use of incident command, because it has been a challenge throughout all disaster responses. Thank you.
Yeah, addressing your two questions together, I unfortunately don't have an answer. Gururaj will probably have more insight addressing maybe the 108 model versus Apollo and the partnership, but this continues to be a very big issue where there's a very large stratification between those who can afford the insurance, are within those systems. We run into it in a minor way in Kenya, in a more major way in some other places. And unfortunately, sometimes, or many times, care follows the money. Maybe a more extreme model would be Navy Columbia, where the county government put in place a reimbursement process for those who had orthopedic injuries. So all of a sudden, popped up all these orthopedic hospitals and orthopedic ambulances, and they would actually drive around trolling for patients. They would then take them to that orthopedic hospital where they were treated, and as soon as the orthopedic injuries were treated, they would bust them off to the public hospital to treat the rest of their injuries. As an extreme model, but I think it's true. I don't think that most centers are malicious about it. They just unfortunately have to be able to make money, and we've had many examples where it's a problem. One approach we've taken in Kenya is to try to engage the ministry at the national level. I don't know that it's always the best way or is the only way, but that's the way approach we've taken, and it's been a great struggle to make it a priority. And that's why I talked about it, is that we're trying to make it on a national level so that, as we spoke of before, we're trying to reach everyone, not just those that haves and have-nots.
Well, the public-private partnership program that has been coming up in India and many other countries in the last decade has really gained ground, and it's becoming more and more over a period of time. And especially with new regulations coming in where corporate social responsibilities are also added on to this, it's leading the way to public-private partnerships. The thing is, there has been very little evaluation that has been done on the merits and demerits of this over a period of time. We have very few evaluation studies that have been done in India that have looked at this particular model. And this needs to be evaluated not in just terms of administrative or financial angle, but in terms of the impact it has on the overall society and also the long-term sustainability of these programs. And such type of an evaluations have not been done. So it's difficult to answer. Even though PPP is getting prominence and is being implemented more and more, we need to answer several questions in this area over a period of time. The second question, which you said, what is it we would take from the high-income countries? My answer would be not to repeat the mistakes that have been made. And I think it's very important because we now see in the literature, Ken mentioned that some of the systems that have been developed in the US or in Europe or many other countries over time they've helped, and overall trauma systems have contributed for a 10% reduction in mortality. But at the same time, it has also turned out to be a very economically intense program. And many countries are now finding it difficult to sustain this, to maintain this. So I think what is required is learn the lessons from this. And there are things, for example, the accreditation systems. And that's gaining ground in many LMICs now, especially with many of the new funded programs that are coming in, where through the system you are trying to improve the overall quality of the healthcare institutions. Like that, there are certain lessons that can be learned, which can be taken. But we also need to keep the mistakes that have been done and not to repeat the same.
Thank you very much. I thoroughly enjoyed this session. We've gone from the broad to the specific, and the examples that you presented, I think are great case studies in terms of how local regions and even countries can deal with the issue of trauma care. I'd like to, with this, I think we can conclude. I'd like to invite everybody back at 3:30 after a coffee break, and we'll see you then.